Excellent. So I think everyone that was waiting has now joined us, and I'm sure we'll have some more join us as we go throughout this evening. So really, I should start by introducing myself. My name is Fern McDonnell, and I am the Health Scheme Manager at the Kennel Club. And I'm really pleased to be here with you this evening to introduce you to the Kennel Club and British Veterinary Association's new SM project. With this project, we aim to deepen our understanding of Syringomyelia in the Cavalier King Charles Spaniel, and we really hope that this is going to help us gain valuable data in order to safeguard the future of this breed, which is loved by so many of us. However, I must say now, please be aware that we are unable today to offer you any individual veterinary advice, and so please do make sure that you contact your vet directly with any concerns that you may have about your dog at home. I'm pleased to say that today we are joined by Professor Mike Herrtage, who is a professor in small animal medicine, and Mike will begin the webinar today with an overview of Syringomyelia and the methods for screening for it. I will then come on to outline the project objectives, the selection criteria, and explain how you can get involved. We will then open up to a Q&A where we will also be joined by geneticist Dr. Joanna Ilska. Please be aware that you won't be able to speak during our webinar today, so please do not raise your hand. However, as mentioned, we will be welcoming questions at the end, and we've already received some pre-submitted questions, and you'll also be able to use the Q&A feature to ask any new questions that you may have. Therefore, without any further ado, I'm going to hand over to Professor Mike Herrtage for him to introduce you to Syringomyelia and the screening methods. Over to you, Mike.
Okay, thanks very much indeed, Fern, and good evening, everyone. And I hope my presentation will be understandable to you all. To discuss this, we need to talk also about the Chiari malformation, as well as Syringomyelia. So this will be a review of the whole system and the previous screening tests that we had in combination with the Kennel Club and the British Veterinary Association. If we go back in time, in the 19th century, Charles Prosper Oliver d'Angers was a French anatomist and pathologist, but also a clinician. And he wrote the first really important treatise on the human spine or cord and the injuries and conditions that occurred within the spinal cord. And he noticed that in some people, there were holes in the middle of the spinal cord, and those are what now are termed as Syringomyelia. We'll talk about those and why they form a little bit later. But that was the first description of these changes, and he's credited also with introducing the term Syringomyelia. Now, Syringomyelia is called a number of different things in various texts. So Scoopel in 1865 called them hydromyelia, which means, of course, water within the spinal cord. Simon then returned to d'Angers' first description and called them Syringomyelia. And for those of you who are not clinicists, syrinx is a Greek word for a pipe, and this is a pipe of fluid within the spinal cord. Other terms such as hydrosyringomyelia, so water in a pipe in the spinal cord, or syringohydromyelia, which is the other way around, a pipe with water in it in the spinal cord, are other terms that are synonymous with Syringomyelia. But Syringomyelia is now really the most accepted term. We'll see some MRIs later, but this is a T2 weighted MRI, taking transverse slices through the spinal cord from the cervical area. And you can see that there's a little white area that gets bigger and bigger and bigger, and that is full of fluid because fluid is white on a T2 weighted MRI image, and that is a syrinx shown in transverse section through the cervical cord of a dog. Now, the other person that was involved in this condition in Cavalier King Charles Spaniel was Hans Chiari. Hans Chiari was a was an Austrian pathologist. He is credited actually with two conditions named after him: the Arnold-Chiari syndrome, which is the one that we will be talking about, often abbreviated to just the Chiari malformation, and the Budd-Chiari syndrome, which is more to do with fluid in the abdomen associated with blockage of the hepatic veins. So he was quite an influential person in the late 19th century and early 20th century. Now, from the point of view of the Chiari malformation, this is a change in the cerebellum, which is the rear part of the brain in the dog, or the lower part of the brain in humans, where it abuts onto the spinal cord. And in the type 1 malformation, he noticed a downward displacement of the cerebellar tonsils, the sort of edges of the lobes of the cerebellum, as it passes into the cervical spinal canal. A type 2 is a rather worse formation of that. That's where more of the cerebellum and indeed the fourth ventricle, which is within the cerebellum, goes downwards into the spinal canal. Type 3 is the whole of the cerebellum more or less goes into the spinal canal. And type 4 is where there's a lack of growth of the cerebellum. So in dogs, we call it a Chiari-like malformation, but it's really like a type 1 malformation in the dog. And why do we get this in Cavalier King Charles Spaniels? Well, it's partly due to their slightly brachycephalic nature. If we look at a normal dolichocephalic dog with a long nose, we find that the brain is more sort of horizontal, and there's plenty of space for the cerebrum as well as the cerebellum. The cerebellum has a nice round shape, and then we have the midbrain coming down into the spinal cord, which goes off to the right-hand side of the slide. Whereas in a brachycephalic breed, often the nose comes back, the brain tilts downwards, so the nose would be coming off sort of at this angle. The cerebrum is slightly squashed in the cranial vault, but most importantly, there is a loss of the volume of the caudal fossa. And the caudal fossa is where the cerebellum sits along with the midbrain. And so you get this indentation in the caudal part of the cerebellum, and these vermis goes through into the spinal cord and causes compression of the spinal cord in the foramen magnum, which is the junction between the brain and the spinal cord. We'll come back to those terms a little bit later, but we also need to talk about the development of cerebrospinal fluid. So because the brain is within a bony box and as along with the spinal cord, it has to adapt to certain changes in volume. And those changes in volume can come from increased blood flow and from movement. And to keep the brain the same volume, there is blood flow in, and there's within the brain this ventricular system which fills up with fluid, this cerebrovascular fluid that maintains the volume of the brain. It also provides cushioning of the brain should the brain have any impact. And the brain tissue is divided into the cerebrum, which has the lateral ventricles and the third ventricle. Then there's an aqueduct which goes to the caudal part of the brain in the caudal fossa, which has the cerebellum. and beneath that the fourth ventricle. And then from the fourth ventricle, the CSF, as we call it, the cerebrospinal fluid, comes from the production in the lateral ventricles down through the aqueduct into the fourth ventricle, and then out into the lateral apertures around the brain and spinal cord, but also into the central spinal canal, which we'll see on these later images. So if we start off with the production, the lining of the ventricles has this epithelial lining which secretes this fluid, this CSF, which is low in protein, low in cells, just really very close to water, really, that fills these spaces. And these spaces, normally, this is a transverse section through the cerebrum, includes the lateral ventricles and here the third ventricle. And you can see that they're quite small, and sometimes they're only a slit-like opening, and they can get larger as the fluid space gets bigger. But from that, and this is a midline, we call sagittal section, so this is right in the middle of the brain, between the two cerebral hemispheres, so we can't see the lateral ventricles because they're in each of the cerebral hemispheres, but we can see the third ventricle. The third ventricle here sits around this point which joins the brains together, the interthalamic process, and then passes down through the aqueduct into the fourth ventricle. And the fourth ventricle sits under the cerebellum, and the cerebellum's a nice sort of roundish shape, but then goes off, and what we can see here is it goes into the spinal canal as the central spinal canal there. We've also got CSF, which is white, surrounding the spinal canal, and also a little bit around the brain that you can see around there. And that's what comes out from the lateral apertures of the fourth ventricle. Now, how does a syrinx form? Well, the thought is that because we have this part of the cerebellum going through into the spinal canal, because this caudal fossa, this area here, is not big enough to accommodate the whole of the cerebellum, that this puts pressure on the spinal cord, and that pressure allows pulsations of CSF to pass down the central canal down here, and that can break through the wall of the central canal, forming these large lacunae of fluid within the spinal cord, and they're what we call syrinx or syringomyelia. And we know that it's a common problem in the Cavalier King Charles Spaniel. It has a complex trait with moderately high inheritance. The difficulty for us as clinicians and for you as owners is that the signs, firstly, are not usually apparent before 6 months of age. Indeed, if they become apparent at all, because many of the cases that we see as normal individuals show no obvious clinical signs, and that relates to, depending on the service, between about 46 and 70% of cases. So a large number of cases are, for part of their life at least, asymptomatic. Now, having said that, because we screen a lot of Cavalier King Charles Spaniels and have over the years, they come in often for the day. They sit in a cage. We can observe them in the cage. Then they go through for their MRI, and then they recover in the cage and they go home in the afternoon. And when we watch them in the cage, many of these so-called normal animals are not actually behaving in a normal way. They may show some scratching, they may show some head tilt, they may develop some curvature of the spine. And those may be temporary signs that the owner just thinks is part of their normal behavior. But when you've seen a lot of these, you realize that they're not severely affected, but they have got some of the clinical signs of syringomyelia. The more serious clinical signs include pain around the head and neck, often that the animals don't want to be touched, particularly around the head or neck. They may show severe pain if you touch their ears, for example, giving the rise to the thought that they might have an ear infection. They may scratch at their neck, often missing their neck, just scratching into midair, something that a lot of puppies will do anyway, and therefore you may think that that's just normal for that particular animal. They may, of course, show screaming or yelping, and those signs can occur intermittently, but obviously the animal suddenly feels some pain or discomfort associated with the syringomyelia. And they can long-term develop this curvature of the spine or paresis or paralysis from the changes in the syrinx. And this syrinx can extend the whole way down the cervical and thoracic and lumbar spine. So here is a case where we've taken out the whole of the spinal cord. You can see that in the cervical cord, there are some obvious changes, big holes there, but there are also some changes back here in the thoracolumbar area. And so we can see these changes around at various points in the cord, but they're most prevalent in the cervical cord, which is why we concentrate on that area with the MRI studies, because if that area is infected, it may be in other areas. There are very few cases where you get it in other areas of the body, like the thorax or the lumbar spine, without it being in the cervical area. So looking at the gross pathology, we can see that in this particular case, the animal has quite widely dilated lateral ventricles, a fairly big third ventricle, and the aqueduct also is moderately dilated. That in its own right doesn't cause any clinical signs unless that pressure changes dramatically. But when we have the Chiari malformation and the pressure changes in the cervical cord, then we see this central canal getting wider and wider. And that syrinx may be because of a widening of the central canal, or it may be in tissue just adjacent to the spinal canal. And I think we can see that in these histological sections. These are bits of the cervical spine from a number of animals that have been fixed and then cut and stained. So we can see the cord. This is the whole of the cord. Around that will be the meninges, the CSF. The central canal is in the middle. That's probably about a normal size of the central canal. That is a defect of the processing, where the cut tissue has just fractured a little bit. But this is the development of the syrinx. So we have a flat syrinx here, triangular syrinx here. Both of these, and this one also, a more rounded one, involve the central canal. But this one here, quite separate from the central canal, is a syrinx that isn't connected to the central canal. So some of them are connected to the central canal, some of the dilations of the central canal, some of them are slightly separate from the central canal, but have come from fluid coming out of the central canal, we think, into that particular area. And some are just very large and incorporate all the areas. The other feature of the condition is that it tends to get worse with age, and this is a sign of animals that have been scanned under the scheme. So the owner or primary vet contacts an appropriate MRI scanning center that does the screening. They follow the procedure notes that are set up by the Kennel Club and the BVA. There's a minimum age of 1 year. There's no upper limit. But if you really wanted to catch most of the Syringomyelias, you would then do them around about 5 or 6 years of age. And obviously that's not appropriate for breeding because these animals are often bred from 1, 2, 3 years of age. And therefore we can't always say how severe they're going to be because there is this development with age. So looking at older animals and sometimes doing more than one scan during their lifetime is the best way to screen these animals for the development of Syringomyelia. In the scheme, the animals have to be permanently identified. Of course, now they would be all probably microchipped, but microchips provide us with another little problem for MRI imaging because MRI imaging involves strong magnetic fields and electrical impulses and radio waves. The microchip will actually cause quite a severe artifact. So if you're taking some puppies in to be microchipped and you have Cavalier King Charles Spaniels, then I would suggest you ask for those microchips to be placed behind the scapulae rather than in the tissue around the neck. Usually they're slightly off center, so they don't always interfere with the image that we've got in the midline, but sometimes they can, and that can be quite difficult for us to resolve. For this scheme that is the Kennel Club BBA scheme, the owner completes a section which verifies the details of the animal and allows the results from that particular animal to be used for certain investigations and research. And this is the part of the form that an owner fills in, and these are the permissions that they give for the results to be published, for the results to be kept, and statistical analysis to be done on those samples. All the images are done in what's called DICOM format. And DICOM stands for Digital Imaging and Communications in Medicine. And it's a system that is being designed specifically so that the information from the patient cannot be divorced from the image. So wherever you look at the image, the information that goes along with it and cannot be separated from it. And that is important both in human medicine and veterinary medicine, that images that you might just take a photograph of the screen, a normal JPEG image, for example, doesn't have that information. You may have the information of the time that it was taken. You may, if you've got an iPhone, for example, have the situation where it was taken, but it doesn't give you the information of the patient. So this is all tied in, and that's why we insist on DICOM images, which can be stored and reproduced and sent to other destinations to be looked at in exactly the same way as we would look at them when they're made with the MRI or CT or ultrasound imaging. So the Kennel Club number obviously needs to be there, or other appropriate identification of animals, because we do get quite a few animals from abroad to grade under the scheme. The MRI processing for restraint, the animals need to be motionless apart from breathing for several minutes whilst the MRI has been acquired. And for those of you who've perhaps been subjected to an MRI, you'll know that it's quite a noisy procedure. There's lots of clicking and sounds that go on during the MRI process as the magnetic field is changed. The radio frequencies that come out are collected by the various coils around the machine. And the acquisition of a scan usually takes several minutes, and often we take several different scans. So we'll talk about those in a moment, but if we're doing 3 scans, then we're talking probably about 10 minutes of scanning, providing the animal remains motionless throughout that period. And to make the animal motionless, it can have general anesthesia, which is obviously quite expensive. More for this sort of screening process, we use narcosis or deep sedation, where the animal remain motionless but isn't actually under general anesthesia. We often put earplugs in their ears so they can't hear the change in sound as the machine makes its scans. The animal is then placed usually into a coil which receives the radio waves under the magnetic field, and then that's processed into the images that you will see in the pictures that I will show you, like this one here. Now, for positioning, we take 3 views. The 3 views are 2 in the sagittal plane, that's the midline plane that runs right the way down the spine as far as we can go. And those are taken in a T1 weighted image and a T2 weighted image. And in the T1 weighted image, the water or the CSF is black around the cord, and if the cord is dilated with a syrinx, then within the cord as well. And we include that interthalamic adhesion, the mid part of where the brain connects from one side to the other, to as far caudal down the neck as we can go with our field of view, but certainly to the level of the C4, C5 disc space. So this is C1, C2, C3, C4, C5. So we need to go down as far as this. And some machines will go a lot further, but others will be restricted to that particular dimension. The thickness of this slice, so this is just one slice, there'll be another slice on either side and so on and so forth across the whole width of the spine. And the thickness of those slices must be less than 4 millimeters. They're 4 millimeters, then there's a 0.4 millimeter gap, then another 4 millimeter slice. So we include the whole of the spine from one side to the other with those 4 millimeter slices. Then we repeat exactly the same acquisition, but in a T2 weighted mode. And in a T2 weighted mode, fluid is white. So the fluid around this cervical spine is white, and if there are changes within the cord, that too will be white, but normally it will be a grey colour. And again, the maximum slice thickness is 4 millimeters. And then we do a transverse, and that transverse across the cervical spine can be done in either T1 or T2, depending on whether you have a high field or a low field machine, which produces different quality of images for T1 and T2. So we allow some variation there. And those should be perpendicular to the spinal cord through the maximum width of the syrinx if there is a syringomyelia present. If there's no syringomyelia present, then we want a block of the cervical spine from T2, C2 to C3, extending to the midpoint. Sorry, a block that is centered on C2, C3, so it goes up from that and down as far as C4. So we have the whole of the cervical spine in transverse section between C1 and C4. And here you can see a normal cervical spine in a T1 mode. So the black is the fluid around the cervical spine. We see this sort of butterfly white area in the middle. That is the gray matter. And then the white matter around it is this grayish area around it. And in the center of there, you may just see a little spot that relates to the central canal. That will be normal, and these are obviously abnormal. They contain large fluid-filled syringomyelia. Here a rather oblique one, and here a round one that, if you look at it, takes up nearly all of the cervical spinal cord, and yet this animal was ostensibly normal from the owner's perception. The second part of the form needs to be completed by the veterinary surgeon. That is, that they checked the microchip number or the tattoo number. They check the date that they've taken the scan, and they've signed that they've done that, and they've looked at the section A that the owner produced. And then those images go to the BVA, and the scrutineers are for the CMSM scheme, then look at these images and grade them. And they grade the Chiari malformation first, and then they grade the Syringomyelia. And a grade 0 means there's no Chiari malformation. The cerebellum has a nice rounded shape, perhaps a slight indentation down the caudal border of the skull. There's the skull, there's the cerebrum there, the midbrain here, the spinal cord coming out here. So C1 and C2, the cervical vertebra that you can see there. So if there's CSF, and that on T1 will be black, and on T2 will be white, is around the cerebellar vermis. That's the ventral aspect of the cerebellum as you go through the foramen magnum, which is the joint between the brain and then the spinal canal. A grade 1 is where the cerebellum does not have quite such a rounded shape. It's more pushed in, and there's no CSF present in that caudal area. We're now in the spinal cord here. So in the caudal fossa, there is no white and there's no black CSF. The vermis is pushed right into that, but hasn't gone through the actual junction. And the junction for the foramen magnum goes from the occipital bone here to the basioccipital bone beneath it. For grade 2, then the vermis has gone through, it's impacted into and herniated through the foramen magnum, so it's now in the spinal canal, and you can see that as this little triangle of tissue having gone through into the spinal canal. And you can see in this case there is a fluid-filled syrinx, black in T1 and white in T2. Now, for the criteria, we draw the foramen magnum as a line between the ventral aspect of the supraoccipital bone, this black bone here, and the caudal aspect of the basioccipital bone, this black bone that comes along here. And if there's The vermis pointing caudally beyond that line, then that is a CM2 or a Chiari malformation, grade 2. Now we have to be slightly careful because there's a ligament that attaches between the bone and the first cervical vertebra, the atlanto-occipital membrane. That is also fairly dark, and we need to make sure that we don't include that as bone because it changes where we would draw our line. Our line would be from here to there, and therefore the vermis is just through in that particular case. The positioning of the head is also important. We like them in an extended view, although actually in the flex view, more of the cerebellum goes through, as you can see in these two images from a same animal done with its neck extended, that is flat with the cervical spine, whereas if we flex the neck, so we bend our head downwards, then we get more of the vermis through into the spinal canal. Now, when we come to the syrinx and syringomyelia, syringomyelia is defined as this fluid-filled cavity within the cord. It may be or include it may include the central canal or may be distinct from it, as I mentioned before, and it's graded to its maximum internal dimension. Now, often it's round, and so we can measure in either direction. We want the largest dimension, so we measure both. But if it is oblique like this, we would measure from one side to the other in that particular case. A pre-syrinx is defined as spinal cord edema, or swelling of the cord with fluid within it, which may be a transitional state prior to the development of syringomyelia. We're pretty sure, although we don't always follow these animals up sequentially with MRIs, that these pre-syrinxes are the development of a syrinx in the longer term. And that syrinx is likely to be slightly away from the central canal. So the pre-syrinx is seen on the T2 weighted scan as this rather indistinct white appearance within the cord, which is associated with increased fluid content. It's not free fluid, so you won't see it necessarily on a T1 weighted image as dark. It may be that the grayness of the cord is slightly blacker than normal, but that can be difficult to appreciate in some of the scans. But if we see a pre-syrinx, we define it as a transitional state. So the grading for the syrinx, which will also be emphasized with age because of this increased tendency to develop syringomyelia with age, is that if it's normal, there's no syrinx there, then that's grade 0. Grade 1 is where we see central canal dilation, which has an internal diameter of less than 2 millimeters. Normally, the internal dimension of the central canal is much less than that, but we've defined it as 2 millimeters, and that is pretty internationally recognized as the cutoff for a normal central canal. Grade 2, however, is where you have syringomyelia. That can be central canal dilation, which has an internal dimension greater than 2 millimeters, sometimes a lot greater, or a separate syrinx. As I mentioned before, the syrinx may be separate from the central canal, or a pre-syrinx with or without central canal dilation. So a pre-syrinx automatically means that you get a grade 2. And then we define that grade with an age suffix. So if the animal is greater than 5 years, it gets an A, or A star if you like. 3 to 5 is B, and 1 to 3 is C. And that means that if it has a grading of, say, 2C, that it may get worse with age. If it's a 0C, then it may develop a syrinx subsequently when it gets older. So this is an animal that is C2, CM2, so we can see the cerebellum coming through here. It's also because of this syrinx, or this central cord dilation, which actually is less than 2 millimeters in diameter, gets a grade 1, and because it's a youngish dog, it gets then suffix of C. So that's how the system worked for those particular cases. And just lost my ability to move forwards, which is, there we are. This one has a CM2, and the reason that our project is not looking at CM particularly is because most Cavaliers have CM2. And so what we're really interested in this project is just on the Syringomyelia. So this is a CM2C, so it's a youngish dog, but it's got a very large syrinx that you can see multiloculated down the cervical cord there. And that's put into this table on the BBA Kennel Club scheme. And if there is a syrinx, then we measure the widest width of the syrinx. The scheme is good because it's quality assured. There's a standard protocol, standard assessment. It utilizes 2 scrutineers to produce the grading. So if one is having a slightly off day, or it's between 2 particular grades, then those 2 scrutineers will debate as to which grade it should go into. And if necessary, then there's a third person who can be involved, which is the chief panelist. And for all of that, there's an appeals procedure. So if somebody feels they've been harshly treated, then they can appeal against the grading, and that grading will then be looked at. And if the grading is changed, then the money for the appeals process is returned. So it's open, it's transparent. Those results were all published and given to the Kennel Club, if the animal was Kennel Club registered. Now, looking at the scheme so far, up until this month, in 2024, you can see that most animals that have been screened are Cavalier King Charles Spaniels, followed by the Griffon Bruxellois, followed by the Chihuahua, the Affenpinscher, and then the various other breeds at much lower levels. And a total of 805 animals have been through the scheme. They're not all, as I mentioned, UK animals. We do grading for the Nordic countries, for New Zealand, and for other countries occasionally when they send us the MRI scans for interpretation. So that's all I have for you. If you have any questions, then do put them into the Q&A box, and we'll deal with those after Fern has presented our next project, which is the Syringomyelia project, and what that's going to entail. So over to you, Fern.
Thank you, Mike. That was a really detailed presentation, and I'm really pleased that you were able to share all of that information with us this evening. Okay, so as mentioned at the start, we wanted to take this opportunity to introduce you to the new Syringomyelia project, which is being run in partnership with the British Veterinary Association and the Kennel Club. I'm hoping to cover the project goals, the long-term vision, and also some information for how you can get involved. So you might be wondering what initiated this project in the first place. And it all started from listening to feedback from both breeders and owners. And we learned that breeders wanted a more effective tool to reduce the risk of this disease. With this in mind, we developed this initiative in order to gather MRI, genetic, and confirmation data with the aim to improve our understanding of Syringomyelia in Cavaliers. In turn, we're hoping this is going to help guide informed breeding decisions, but also with the ultimate goal of developing estimating breeding values, which we believe is going to be a really powerful tool to address what we all know is a really complex genetic condition. So, what makes this project unique? Well, for the first time with this condition, this project will be focusing on a pre-selected group of Cavaliers. These have been chosen based on criteria which is basically designed to maximise the data's impact and the relevance. With this project, we're aiming to screen 500 dogs over a 5-year period, and we're hoping that this is going to give us the data that we need to achieve those overall goals. So, when we were designing the criteria, it was really important for us to bear that in mind. So our first criteria relates to age. And initially, we're going to be focusing on dogs that have been born between 2013 and 2018. The reason for this is it takes us back to what Mike was saying earlier. We know that this is a disease that progresses with age, and therefore it's really important for us to minimise the risk of selecting younger dogs that may currently appear unaffected, but could go on to develop this condition later on in their life. The second criteria relates to breeding. And it was decided that we would give priority to dogs that have had at least 3 litters. This is because dogs that have been bred from have had a greater impact on the population, and therefore they're going to provide more value for EBV calculations compared to dogs that have not been bred from. Finally, we also wanted to make sure that the dogs that we selected represented a variety of family lines. And therefore, our geneticists carried out a piece of genetic analysis using the MCA method, which is referenced on the screen. And if you're interested in further information on this, please do ask later on in our Q&A session, or contact us via email, and we'll always be happy to share further details. So, another really unique factor about this project is the subsidies that we have available. We completely understand that cost can be a prohibitive factor when health screening, and we wanted to make this project as accessible as possible. So we're really pleased to have the generous donation from the Kennel Club Charitable Trust, which is going to be able to allow us to offer subsidies for all project participants. So if we break it down a little bit, first of all, we've negotiated a fixed fee with all participating centres of £1,000 for the MRI. This has been reduced from the typical range, which is usually around £1,000 to £4,500. This is then going to be further subsidised by £700 by the Kennel Club Charitable Trust, which means that owners will only have to pay £300 for the MRI. There will then also be a £50 screening fee, which has been reduced by the BVA from the standard £100. Therefore, in total, owners are going to be responsible for paying £350 to have their dogs screened under this project. This will include £300, which is payable directly to the participating centre for the MRI, and then also the £50, which should be paid directly to the BVA via their Canine Health Scheme phone line. The outstanding £700 on the bill will be paid directly by the Kennel Club Charitable Trust, and this therefore means that owners don't have to upfront that cost, and it will be covered by the Kennel Club. So, how to participate? As mentioned, this project will work on an invitation basis, so we would ask you to wait for an invitation, which will be sent via email from the Kennel Club. This invitation will contain all of the information you need, as well as the registration form and a list of participating centres. We would then recommend owners to review the list of participating centres and choose the one that's most appropriate for them. They would then need to contact this participating centre directly and ask for a MRI appointment and quoting and referencing the SM project. Owners will then need to complete the registration form, and this needs to be done at least 14 days prior to the appointment. This is then what's going to allow us to arrange for the subsidies to be released to the participating centre, meaning that the owner then doesn't have to upfront that cost. Owners will then need to pay the £300 MRI screening fee to the centre and also call the BVA to pay that £50 screening fee that we've mentioned. The MRI scans will then be sent over to the BVA for screening, and the results are going to be returned to the owner via the participating centre. So a couple of additional points there. The BVA will aim to return results within 4 weeks from the MRIs being received, as well as the payment, the £50 screening payment. Owners should always contact the participating centre directly for updates, as the results will go via the participating centre. To find a list of participating centres, this is going to be available on the Kennel Club website and the BVA website. And as I've mentioned, a full list will also be included in that invitation. However, what I would say is please do reference back and check back on that list. We are going to be continually recruiting, so you may find that there isn't a participating centre near you at the time and that you're not able to travel to your nearest centre. However, please do reference back. It may be a situation where we recruit a centre nearer to you later down the line. And we would also say, if you've got any recommendations or any centre that you would like us to consider, please do send us over those details and we would be more than happy to reach out to them directly. Lastly, we have also, thanks to feedback from the breed, we've arranged that DNA will also be collected as part of this project. So when a dog is presented for an MRI appointment, a simple cheek swab will also be taken at that time, and then this is going to be returned for storage, and then this will be made available for future research purposes. So, whilst this project is running, all of the individual results will be confidential, after which we will then be making this publicly available in order for us to be able to, well, for the data to be able to contribute to the development of future estimated breeding values. However, we will make sure that throughout the project that the anonymised data is shared by the Breed Health and Conservation Plan. We will also be able to make this information available upon request. So if you are interested throughout the project about the progress, please do contact us directly and we'd be more than happy to share this in an anonymised fashion. Okay, so I just want to touch on the invitation process and then we're going to move on to the Q&A session. So first of all, the selected dogs should be receiving their invitations in January 2025. Initially, we're going to send out these invitations in the first batch is going to be the first 100 dogs, and that's going to represent the lines that had the greatest influence on the most recent litters. So that will be the litters that were born in 2022 and 2023. Owners are then going to have 1 year to participate, after which that invitation will then be passed on. However, if an owner can't participate in that first year but does want to be involved, we would just say contact us directly and we'd be more than happy to extend that invitation. It's all going to depend on uptake, and it's possible that we're going to send out multiple batches within 1 year. And we may also need to adjust our criteria slightly as the project progresses. However, of course, if we do need to adjust that criteria, we will keep the breed informed so you know what the selection process is looking like. So I think that leads us nicely on to our Q&A session. So I'm going to invite Joanna and Professor Mike Herrtage back onto the screen with me. I know we've had some pre-submitted questions, which is brilliant. So we'll go through some of them first, and then please do enter any new questions into the Q&A feature, which you should be able to access either via the top of your screen or the bottom of your screen, depending on which device you have joined us on. And there should just be a button that says Q&A. So hopefully if you click that, it gives you the opportunity to enter any new questions you may have. So, Mike, I hope it's okay. I'm going to come to you first of all.
Okay.
One of the first questions that we had submitted was, why do some dogs with poor scans have no symptoms? I know you briefly touched on this in your presentation, but I wonder if you could elaborate a little bit further for us.
So it is a very good question, and one that I we don't actually have an answer for. We have some theories. The theories are that the more pulsations you get of CSF going down that central canal or down that syringomyelia, the more likely it is to upset the nerves in that area, and therefore you're likely to get clinical signs associated with that. The pain ones would tend to be affecting the slightly more dorsal horn nuclei, which are the sort of sensory pathways that are taking pain sensors from various parts of the body. So if the dorsolateral areas are affected, then you could expect there to be pain associated with it. So it's a question of the area that's affected. It's a question of the fact that brain doesn't like change, and therefore, if there are pulsations going through that syrinx, you're likely to get clinical signs. But the dog has virtually its whole of its cervical cord filled up with fluid, and still manages to walk around and do things normally, is perplexing. I remember when I was a young clinician, and we had an animal with hydrocephalus, and that's fluid within the brain. And when you saw this animal, apart from having a slightly domed head, it was reasonably normal. It could do things reasonably normally. It could learn fairly normally. But actually, at post-mortem, it had just a wafer thin brain, yet was able to do most of the things that we can do, which just shows that actually we only use about 5% of our brain to do what we do on a normal daily basis. So there's plenty of reserve there, and it's a question of which reserve parts are there intact as to whether or not you'd be normal or show signs of clinical change. So it's not a good answer, but it perhaps explains why some animals with poor scans don't have clinical signs.
Absolutely. Thank you for that. And another question that we had, which I will try and answer for you all, and then by all means, Mike and Joanna, if you wish to add anything as well with your own expertise, please do so. But this question was mentioning that the breed has been scanning for over 20 years, and therefore, what are the aims and objectives of this new project? And I thought this was a really good question, because actually it's completely true that the breed have been screening for a really long time. However, we must caveat this with that there is still a significant gap in the data that we have available for the Kennel Club registered population. The official CM-SM scheme that Mike talked about was launched over 10 years ago, and you have all seen the participation figures that Professor Herrtage shared with us earlier. However, only 60% of those screening results have been linked to a Kennel Club registered dogs. And so with this in mind, we really wanted to take a fresh approach with this project, and we wanted to look at how we could encourage participation in order to gather that larger data set for us to improve our understanding of the condition within the breed now. And so in order to do that, there was a few things that I noted when I spoke earlier. And so firstly, we really wanted to focus on the dogs that made the most significant contribution to the current population, as that's not something that has been done previously. We're also really fortunate to have the support from the Kennel Club Charitable Trust, which is making it possible for us to subsidise the cost of the screening. And this is then going to be available for every participant. We're hoping that this will make the screening far more accessible, and also that this approach will encourage more participation and therefore provide a clearer picture of syringomyelia in the current population, and in turn then be able to give us that much needed data in order to be able to develop the really useful tool of estimating breeding values, which is something that we've never had for this breed previously. I don't know, Mike or Joanna, if you wanted to add to that, or I will move on to the next question.
Well, I think you've said it all really, Fern. That is that we need to move on to estimated breeding values, because the cost of MRIs for the general Cavalier King Charles population is so enormous that it's just, there has to be another way. And people have looked at other ways of measuring various things to see whether there was an external way of trying to make this diagnosis, but none of them have come up really with a good answer. They may do in the future, and then MRI may be put on the back burner, but at the moment the only way to make this diagnosis is with MRI. And I realize it's expensive, it's time consuming, and that you have to travel probably to a center to have that done, because your local practice probably doesn't have an MRI. So all of those things makes it very difficult, but also the more reason why we should do it, because the popularity of the breed is high, and we want to make sure that it's as healthy as it can be.
Excellent, thank you for that. So another question that we received was, and I'm going to pass this one over to you, Joanna, if that's okay. So to what extent could this screening programme further reduce the gene pool of the breed?
So thank you, Fern. First of all, I would like to apologize ahead of time. My dog had a surgery today, and she's currently taking it a little hard, waking up from the general anesthesia, so I have to keep stroking her. She might make an appearance in a moment, but I'll do my best to answer that question. So first of all, I'm actually delighted that we have a question about the gene pool, because management of genetic diversity is going to be a major topic of focus at the Kennel Club starting. Well, we kind of started already, but it will probably start next year. And of course, the person who asked this question is absolutely right. Whenever we talk about employing selection against any trait, be it syringomyelia, coat color, or head shape, we are going to affect the gene pool. However, this doesn't mean that we should stop selection. It just means that we need to be smart about balancing that selection against the disease and the management of the genetic diversity. No, it is difficult to predict at this point whether there is any risk of this project reducing the gene pool beyond the rate that we are observing now, simply because we don't know how intensely breeders will decide to breed against Syringomyelia, and secondly, how many of those tested dogs will actually come back as clear. We know that in Cavaliers, one of the major issues concerning genetic diversity is the use of popular sires. And unfortunately, none of the current popular sires has been tested for Syringomyelia, at least according to our data. So this would indicate that at this time, selection against Syringomyelia is actually has a pretty low intensity. But I think that the most important point here comes back to what you said a moment ago, Fern, that the goal of this project is to actually popularize the testing and attain sufficient numbers of tested dogs for the development of EBVs. And this is really the optimal solution, because with EBVs, we don't need to select the best of the best. We just want to select dogs that are better than average, and over time we're making slow but continuous progress. And EBVs are actually the best tool that we could have for balancing selection with the genetic diversity. But obviously, it is a very, very valid point, and we will keep monitoring that. And should we see some undesirable trends in the number of litters produced by the dogs participating in the project, we will be addressing this going forward. And as I mentioned, it will tie very nicely with the population analysis we're hoping to be discussing with the breed representatives in 2025. So I hope that answers the question.
That's perfect. Thank you, Joanna. Excellent. So I've seen that we've had a few questions come in from people watching this evening as well. So I'm just going to jump over to the Q&A section. And one of the questions is from Michael and says, does the scheme follow Paul Mendinger's of the Netherlands protocol? Mike, I'm not sure if you wanted to touch on this one. I was just going to mention that Paul Mendinger's is, we have been in touch with Paul Mendinger's and he does now sit on the projects group, which we are really pleased to confirm. However, Mike, if it's okay, I will pass over to you with regard to the protocol.
Yeah, well, I think that we both use very similar protocols, so I don't think there's any great, any great problem with that at all.
Excellent, thank you for confirming. Then we had another question pre-submitted prior to the webinar, which was asking about how we would find participating centres in order to be able to obtain the screening. So just to confirm, we will have a set list of centres that will be participating. So what we would say is that this won't be open to all centres that have MRI facilities. It will be select centres that will be participating. So please do reference the full list that will be available on both of our websites, so the BVA and the Kennel Clubs, in order to be able to find the most appropriate centre for yourself. Excellent. So we've had another question as well over in the Q&A section, and this is from Richard. And Mike, if it's okay, I will hand this one over to yourself, and then by all means, Joanna or myself can also add should you wish for us to. So this is, you appear to be concentrating on SM, which is the result of CM, which is the real problem. Should we be concentrating on Chiari malformation and breeding to avoid the malformation?
Well, that's an interesting question because nearly every Cavalier King Charles Spaniel has CM. And so concentrating on that would be good, but actually to concentrate on that you would have to change the shape of the head to increase the caudal fossa so that it can accommodate the cerebellum, and that's a difficult procedure to do because we don't have any criteria as to which animals might help that. There have been, and you're probably aware of, several outcrosses that have sometimes managed to improve the caudal fossa volume, and I guess that those tests and protocols will go on despite this syringomyelia. But this particular project is to try to reduce the syringomyelia in the hope that that will also probably change the CM grade, because as you realize, the two are connected. And if we can reduce the syringomyelia, then we'll probably produce some Cavalier King Charles Spaniels naturally that have no CM. And if they have no CM, then of course that would help the breed considerably because it would reduce the number of clinical cases in the future. But concentrating on syringomyelia seems to be an approach that may do two birds with one stone. So that's the hope.
That's perfect. Thank you, Mike. We've had another question come in as well. And Joanna, if it's okay, I'm going to pass this one over to you as our genetics expert. So this question is from Sandra and asks that the Netherlands have had compulsory MRI scanning for several years now, and could their results be used for estimating breeding value development?
So it's a very good question, and it actually expands beyond the SM project. We have many other diseases and many other breeds where this would be very, very useful. The problem is that with EBVs, with calculation of EBVs, we need to have a good connectedness of the dogs via pedigree. Now, unfortunately, at this time, the international contracts between the kennel clubs state that the export pedigrees that are shared between the countries typically only include 3 generations. So if we have a Netherlands population, a population from Netherlands that is completely unconnected to the UK population, then unfortunately this would not be useful. However, if there was a way of connecting them, then yes, absolutely. One of the things we would have to consider, however, is how similar their screening procedures are. We would have to address the potential inter-panelist differences. However, this is something that could be done via a research project, basically comparing our data sets and seeing what we can establish from there. However, we do have to remember that those external data sets could help, but they cannot replace the data that we have on the UK population, which is the most pertinent, and hence the SM project. But I will add here, if there is anyone from the breed community who has really close links with the Netherlands, and there is any scope for data sharing between the kennel clubs, then I'm very happy to kind of take that on. Please email the health at thekennelclub.org.uk, and we can have a further conversation about that.
Excellent. Thank you, Joanna. Okay, I'm just having a look. I don't think we've got any more questions this evening. So I appreciate we have gone over by 13 minutes already, and I'm sure many of you want to get back to your evening. So I must finally also apologise. I am aware that some of you have experienced my technical difficulties and therefore haven't been able to see my slides. But please be assured that we have recorded this afternoon session, and we will make sure that those slides are then included in the recording, which we will share with all of the breed club secretaries and everyone that's attended today, to make sure that you do receive all of the information that we intended to share. So once again, I really want to end this session just to thank you for your time joining us today. And we really hope you've enjoyed listening to the webinar and learning more about the SM project. I should also mention that we do also have all of our previous health webinars on our YouTube channel, which is the Kennel Club YouTube channel. And these cover topics such as common cancers, breathing issues in flat-faced dogs, back disease, epilepsy, and many other sort of topics. So please do feel free to head over to our YouTube channel to view all of our previous webinars, and also to email us at health@thekennelclub.org.uk should you have any comments or questions. Excellent. I hope you all have a wonderful evening, and thank you again, and goodbye.
Thank you. Goodbye.
Bye. Bye.